All right, good morning. Today we're going to learn about Chapter 62, Care of Clients with Breast Disorders. The priority concepts for this chapter are going to be cellular regulation, infection, and pain. And the interrelated concepts in this chapter is going to be sexuality. So it talks about benign breast disorder. These are proliferative breast lesions. Puts the patient at high risk for development of breast cancer, which is abnormal growth of breast cells. There's different types. There's the atypical ductal hyperplasia, which is the ADH. And there's the atypical lobular hyperplasia, which is the ALH. Lobular carcinoma in situ also, which is LCIS, and that puts the patient at highest risk for developing invasive cancer. So the patient's going to need to have yearly mammography and twice yearly exams. They need to stop any oral contraceptives and avoid hormone replacement therapy. It can be surgically excised if it's the ADH, meaning the atypical ductal hyperplasia. That can be surgically excised, and they can use a med called tamoxifen. For the proliferative breast lesion without atypia, which leads to a fibroadenoma. This one is benign. It's very common. They'll have a well-defined solid mass of connective tissue. It'll be oval in shape, freely movable, rubbery. This may occur anywhere on the breast and may require needle aspiration in order to determine if it's a cyst or if it's solid. For the non-proliferative breast lesions that involve the lobules or the ducts and the stromal tissue, they'll have fibrocystic changes such as pain, tender lumps, rubbery, and feeling. Very ill-defined, and that's found in the upper outer quadrant of the breast. It should subside after menopause. And then you have what's called ductal ectasia. This is a hard, irregular nipple discharge causing enlarged axillary nodes, redness, hyperpigmentation, and edema. And it's difficult to distinguish from cancer. Women who are approaching menopause, intraductal papilloma. This is a mass in the duct that results in bloody nipple discharge. It's usually not palpable, and it usually occurs in women between the ages of 40 and 55. All right, so it says the pathophysiology. Remember, cysts are simple cilic. They resolve after menstruation and return before the next cycle. That's what that means. They disappear in postmenopausal women, but if postmenopause requires hormone replacement therapy, they may still experience the symptoms. To diagnose it, they'll do a breast ultrasound, mammography, or by needle biopsy. All right. Interventions. We can use the SERMs, which are the selective estrogen receptor modulators. The nurse should instruct the client to limit sodium when taking the SERMs. The intake is before menstruation, which helps minimize swelling and reduces pain and tenderness. They should also wear a supportive bra, even to bed, to reduce pain that's caused by the tension on the ligaments. All right, so then it talks about large breast in men, gynecomastia. This is a benign ridge of glandular tissue which causes the gynecomastia. It's a palpable mass, approximately 0.5 centimeters. It's the most common complaint of this condition will be the tenderness and sensitivity when the clothing touches the nipple. It's caused by some drugs like spironolactone, the potassium-sparing diuretic. If that's the case, then you'll need to discontinue the med. And it can also be caused by some conditions like hyperthyroid and hypogonadism. The treatment is to treat the underlying cause. They can use SERM slash aromatase inhibitors and androgens, or they can do reduction mammography. For women, this can occur with or without obesity, weight loss, or supportive bras are the interventions, and they're tried first. And if they're not effective, then surgery will be done to reduce the breast size. All right, then it talks about women or that have small breasts, so they can get what's called breast augmentation. Most insurances do not cover breast augmentation. They do have a choice between the saline and the silicone. The saline is the safer one. If it leaks, it can be absorbed by the body, whereas the silicone, it cannot. If they do have this procedure, before the procedure, they need to stop smoking and avoid NSAIDs and supplements or herbs that cause bleeding. So anything that begins with a G, like ginseng, ginkgo biloba, etc., and also chamomile and feverview. After surgery, someone needs to be with the patient for 24 hours, and the patient can expect some soreness in the chest and arms for the first few days. The breast will swell for about 3 to 4 weeks. The breast will feel tight and sensitive, maybe warm and itchy. Do not lift, pull, or push anything until cleared by a surgeon. And do not twist above the waist. Walk frequently to prevent DVTs. Continue the breast self-exam. Also clinical exams. They need to get mammography. But remember that it's not as sensitive due to the reduced amount of visualized tissue. They do have a risk for breast implant-associated anaplastic large cell lymphoma, which is a form of non-Hodgkin's lymphoma. Then next thing it talks about is a breast abscess. They're often related to certain conditions like diabetes, clogged sweat glands, acne, or trauma. The risk factors are smoking, obesity, nipple piercing, and the treatment is broad-spectrum antibiotics or ultrasound-guided aspiration, or an IND, incision and drainage. All right, then it talks about, hold on a second. The breast abscess, and then it talks about mastitis. Okay, mastitis often appears as a red, hard, and painful area on the breast, commonly in the upper outer quadrant. Sometimes they like to ask that where it occurs. Although mastitis can occur in both breasts, it's usually unilateral, only on one side. The client who has mastitis can also have flu-like symptoms such as fever, chills, headache, and muscle pain or myalgia. After delivery, the nurse should instruct the client to observe the breast for indications of mastitis and notify the provider if they occur. Then it talks about breast cancer. This can affect both men and women. Men will have a hard, painless subareolar mass with gynecomastia. They may have some bloody discharge from the nipple. Men often don't suspect breast cancer, so they ignore getting treatment and diagnosed. In the later stages, the non-invasive cancer remains within the mammary ducts or the lobules. If it's invasive, it grows into the surrounding tissue, and that is the more common type. Then metastasis takes place where it spreads beyond the breast tissue and lymph nodes via the blood and lymph system. The treatment will depend on the site and level of impairment, and it'll include chemo, radiation, and possible surgery. Then you have the non-invasive in situ breast cancer, and you have two forms, the DCIS or the ductal carcinoma in situ. This is where the cells are located within the duct. And then you have the lobular carcinoma in situ. This is where the cells are contained within the lobules. And it's not considered cancer, but it puts the patient at high risk for developing invasive breast cancer. All right. And then it talks about invasive cancers. It talks about invasive ductal carcinoma and inflammatory breast cancer. So the invasive ductal is the most common type of invasive breast cancer. They'll develop fibrosis, which shortens the Cooper ligaments, and the skin will thicken and dimple, causing this PU of orange. It resembles an orange peel. You need to remember that. Highly tested. The inflammatory breast cancer is rare, but highly aggressive, and it's usually diagnosed at later stages, and it's harder to treat successfully. Now, here's a picture of that orange DePuy skin and the nipple dimpling. All right, then it talks about Paget's disease. Usually progresses from the nipple duct to the nipple surface to the areola. It's critical to see because they often have other types of breast cancer as well. Then it says the triple negative breast cancer. This lacks expression of the estrogen receptor or the progesterone receptor and human epidermal growth factor receptor 2. All right, it talks about the etiology and genetic risk. It says increased age is the primary risk factor for breast cancer in both women and men. Now, there are some risk factors that can be changed called modifiable, and one of those is obesity, also increased body fat, physical inactivity, combination hormone replacement therapy, smoking, and alcohol use. All right, so the health promotion and maintenance. The American Cancer Society says at age 40, they can choose to have an annual mammogram, and then after 45, have one every year. 55 every 2 years if it stays low. They also need to do breast exams. The nurse should instruct the client who has a menstrual cycle to perform a breast self-exam every month about 7 days after menstruation ends. Unless the patient is menopausal, then any time. But she should choose a time and use that same time every month. The nurse should instruct the client to use the sensitive finger pads of the middle 3 fingers to perform the breast self-exam and also into the armpit. The nurse should encourage clients to perform breast self-exams or do an extra examination while showering. This allows the client to concentrate more easily when they're feeling for those changes in the tissue. All right, as far as the assessment, remember you got to consider the modifiable versus non-modifiable risk factors. You want to see if they have any breast mass, and if they do, what the size is, what the consistency is, and whether it's fixed, meaning stationary, or movable. As far as health maintenance, they need routine checkups, breast self-exams, and you need to collect their OB/GYN history. Age of menarche, early menopause, prolongs hormone stimulation, which increases their risk. The age at menopause, whether they had late menopause, that can prolong hormonal stimulation, which increases the risk again. The age at their first childbirth, the number of children and pregnancies, including the number that were aborted. The birth of a first child after 30 years also increases the risk, and also the use of oral contraceptives. All right, so when we're doing our physical assessment, you want to know if the patient's having any bone or joint pain or cognitive changes, which can indicate the likelihood of metastasis. That PU, the orange skin, which is redness and hyperpigmentation, or retraction or ulceration, those can all indicate advanced disease. Also, keep an eye on the patient's psychosocial status, because they will have some fear, some disbelief, maybe in shock, and it could be related to their sexuality, their body image changes, lack of libido, and that could be caused due to the hormonal changes and also the anxiety. All right. We can also look at their labs. They're going to have elevated liver enzymes, which could indicate metastasis, and elevated serum calcium and alkaline phosphatase. That should suggest bone metastasis. A tomosynthesis is similar to mammography, but uses 3D images. The MRI, we can do that for high-risk patients and for better visualization of a suspicious area found on a mammogram. We can also use PET scans, CTs, and MRIs, and these can rule out or identify areas of metastasis. All right, so it talks about other diagnostic tests of breast biopsy versus genomic tests. Breast biopsy is the only definitive way to diagnose breast cancer. Okay, estrogen and progesterone positive respond better to hormonal treatment. They can use the trastuzumab, that specific targeted therapy. As far as genomics, Oncotype, Dex, and Mammaprint are predictors of outcomes, so low-risk women avoid unnecessary treatment. Accurate predictors of the response to therapy we need to monitor for. All right, as far as interventions, we can use complementary and integrative medicine, which includes guided imagery, massage, even prayer. We could do hormone receptor replacements with the hormone estrogen replacements or the metastatic breast cancer treatment. As far as if they have a surgical procedure and they have an incision, the same general principles of any decision, but the extensiveness will depend on how radical the surgery needed to be. Okay, whether it's a breast preserving or a radical mastectomy. Remember to do range of motion and simple things like hair brushing. If they have a drain, you're going to have to care for the drain. Observe the amount, color, odor of the drainage. You'll have to clean and empty it. Put them on arm precautions post-mastectomy. No blood pressure, IV, or lab sticks in that operative site if they've had that mastectomy. Very important. All right, because we're trying to avoid lymphedema, right? All right, avoid lymphedema, avoid trauma to the surgical site. So no blood pressure, IV, etc. They will need arm compression sleeves with elevation and range of motion. If they've had reconstructive surgery, avoid pressure to the breast during sexual activity. Teach them proper breast massage if the implants are present to prevent hardening and deformation of the breast. Of course, per the doctor's order. All right, then this is just a question. Okay, the answer here is D. It sounds like you're concerned about how your body looks after surgery. All right, so that concludes the first chapter.